Yeah, and the thing is, I think residency or whatever you do, right? Whether it's nursing and you're in nursing school, those are the times to really set those ways to deal with burnout, deal with, ethics issues and how you're going to deal with them. Because once you're out, no one may be looking over your shoulder every patient you see or every interaction. And if you get into bad habits of doing things that aren't right, that's going to end up on the news, and you're going to be the one who did that to 10 patients or 15 patients.
Looking at you as a case study.
Exactly. So you don't want to end up in that situation.
Yeah, for sure. Reviewing your old charts, yeah.
Yeah. Any other thoughts on this scene before we move on to the next? Thanks for picking it. It's, like you said, difficult to have a conversation around, but yeah, you made us at least scrape the surface.
Yeah, that was a great scene, man. Yeah.
I appreciate you.
Ready for your scene?
Yeah, cool.
Okay.
Oxygen levels are dropping. Mr. Spencer, how are you feeling?
I don't remember where I parked.
Mr. Spencer, do you know where you are?
It's so loud in here.
Dad, do you know where you are?
Dad, look at me. What's my name?
I don't know where my car is.
IPAP 15/5. Step out.
What's BiPAP?
It is a pressurized air mask that can improve his oxygen. Either his pneumonia is getting worse or his heart couldn't handle the fluids that we gave him to treat the sepsis. His lungs are filling up with fluid.
Can't you take the fluid away?
Not without his blood pressure crashing with very bad consequences. So let's just hope the BiPAP works.
And if it doesn't?
Then I would need to know your decision about using a breathing machine.
We're still talking about it.
Well, we know he expressed his wishes in writing. Do not intubate.
We're thinking try it for a week.
That would be a very painful week. He wouldn't get a lot of rest with all the monitors and all the blood tests. He might need to be sedated. He might need to be restrained because he'd be in an unfamiliar place with a very uncomfortable tube down his throat. And he wouldn't really know what was happening. Elderly patients can often develop psychosis.
But he might get better.
Or he might get worse. What would you do?
I really can't answer that for you. This is your father. That's your decision to make. I can guarantee you that we will keep him as comfortable as possible if a natural death is what you choose.
But he's not your father. And he can recover from this.
What my sister means is that we're still deciding the best thing to do.
Well, the sooner you decide, the better. I'm really sorry. I wish there was more that I could do. I'm not sure that he has that much time left.
Yeah, rough, man.
So unlike the last scene, this happens literally every shift, every other shift to probably all of us. So, Kendall, why'd you choose this?
Backstory for this, this happens over 3 episodes. The gentleman comes in, he starts to decompensate as his day goes on. And he had advanced directives saying that, hey, I don't want to be resuscitated if my heart stops for natural reasons. I don't want to be intubated. But he starts to decompensate, and the family sees this. And the reason why I chose the scene is because it's a very unfortunate situation for a family member to be in. You're basically making a life or death situation about your loved one. It can also be uncomfortable for the physician, especially this case, because, you have a patient that has advanced directives, but now the family's trying to change it, right? And we've all been in this position. As we have an aging population, you're going to be in this position a lot. Yeah. And, and to give, the benefit of the doubt to the daughter, she's not going against his wishes. She, in her mind, is trying to do what's best for her father. She's trying to give him every chance, because earlier in the day, she mentioned that my father's stubborn. He would never quit on me. I'm not going to quit on him. So she doesn't want to quit on her father. She's not really trying to go against this. What she's trying to do is right. And that leads me to think that, to talk about another thing, people focus more on the quantity of life. There's a great book that one of the doctors we work with, Dr. Hiscock, it's called Being Mortal by Atu Gawande. Yep. Great book. Everyone should read it. But it talks about how in modern medicine, how we approach aging and end of life care and death. And it basically says that we focus so much on the quantity of life as opposed to the quality of life. Now, I don't remember this gentleman's quality of life. He's dependent on how his everyday life is, but I just feel like, in our healthcare system, we're just so focused on keeping people alive at all costs, and as opposed to just seeing how what we're doing to them is going to impact their life. With this gentleman here, how Dr. Robbie handled it, I 100% agree with it. Some people would have thought maybe he should have been more on the patient side. The patients had advanced directives, follow that. But I had a thing when I was doing COVID. We were down to one vent in the whole hospital, right? And we were trying to find ways to use multiple vents. We had a patient of 102 upstairs on the floor. The whole hospital kind of got involved because the family was really pushing to intubate this lady who didn't have a good quality of life. She was bedbound, demented, and we only had 1 vent left. I think they didn't end up intubating. The family left really upset that they didn't intubate. They felt like the hospital kind of quit on their family member. And in this scene, Robbie kind of follows the patient's wishes. I mean, the patient's family's wishes, and they intubate him, and they're able to see firsthand that like now he's restrained to the bed. He can't move. He's uncomfortable. He's got a tube down his mouth. They try to sedate him, but then his blood pressure starts to drop. So now he needs some pressors, which requires like a more invasive treatment, which is a central line now. And so the family kind of sees that, oh man, this is not good. Stop everything. Whereas opposed to Robbie would have just fought them and not did it, the daughter probably would have left in her mind like, yo, they killed my dad. They didn't do everything they were supposed to do. He could still be alive. But they were able to see like they did everything. He wasn't comfortable. This is what my dad actually wanted. So you followed it. And that's kind of why I chose the scene, man, because it kind of hit home, like things I experienced in the hospital. And I agree with Dr. Robbie how he handled it. Some doctors may not. They probably would have fought for the patient and say, no, we're not gonna do this unnecessary treatment for him. Right. So I don't know.
Yeah, no.
Oh, sorry. I was just gonna say, I'm recording my voice through here, if y'all don't mind. I actually recently went through that exact situation, like very, very similar, with my brother who passed from HIV, and basically, like my mom couldn't make the choice, and the doctor ultimately asked, do you want to intubate him and, have that small chance, or do you want him to be peaceful, And, well, he was able to still talk, but, kind of like the older guy, he wasn't all there. So that was a whole nother situation. It got, and I'm sure y'all are probably faced with that whenever there's not family members sometimes, but basically we got into this, and y'all can tell me if y'all have ever faced this before, the situation with him where we'd say, do you want to be intubated? He'd say, I do not want tubes down my throat. Do you want to live? I want to live. I do not want to die, but do you want tubes down your throat? I do not want, and no matter what we'd say, he'd say no to both of them. So ultimately we just decided to take the chance and put the tubes, because he kept saying he wants to live. But he was too irrational to understand that you can't have both,
It's a challenge.
Yeah, man.
Yeah, I mean, first of all, sorry for the loss of your brother. I think it all starts with, as in American society, and others have, worded this way better than I will, we just don't have the conversations around end-of-life care enough or to any extent. And a lot of times, the first time that conversation is happening is a scene like that, where, the patient is sick, they can't make their own decisions in that moment, and family is being asked to make decisions that are impossible, essentially. And a lot of patients, what I've found is they will have a DNR or a DNI or their end-of-life care kind of documented, but they never told their kids about it or their other family members. And so I think that's a very important point to make. A, everyone should have those wishes documented, but then B, having those wishes while you're alive and in good mentation, and sharing those with your kids, with your siblings, with everyone around you, so that they're not put in that impossible situation when one day that does happen, and it's coming for all of us. It's going to happen to every single one of us. And so I think that's the takeaway that I take, is that we have to talk about it more.
And I think that this underscores the complexity of relationships and dynamics in families altogether, right? Because even in this scene, the son felt one way, the sister felt another way. And if there is seniority of one sibling over the other, then they may push harder. And it continues to really erode some of the foundational structures of families in front of your eyes. And so as a physician, you're like, how involved do I get in making sure that this bedrock doesn't get disrupted? Or do I just focus on what's written on the paper, what I'm doing for the patient? Because it's all interrelated. There's so many misconceptions around end-of-life care and end-of-life documentation. And we also don't do a great job from the start of a visit talking about these things and introducing these a lot earlier. And so that would be one of the takeaways that I have, is hey, even as clinicians, we need to lead with these conversations more commonly.
But also, too, we're ER doctors, right? People come to the ER to be helped, to be fixed. Like, if you're a primary care doctor, you have a rapport, years of taking care of this family. It's kind of easier to have the conversation. So as opposed, you bring your family here to be taken care of, not for me to tell you, hey, man, let's just try to make them comfortable. They're like, no, fix my family. That's why I brought them here. So they're not in that mindset sometimes.
I'm going to push back on that a little bit. What about the patient who comes in and their touch point with a PCP is a lot less, and they may come in and see us more commonly, right? Or someone we see who has a chronic issue and they're always coming to the ER, and we can start that conversation with them early. We might know. We've had patients who in New York were alcohol, substance use, 25-year-olds, 30-year-olds, and we're like, yo, this is not going to last forever, man.
And they come to hospital every day.
Every day.
They come every day.
And we could easily have just at some point said, You're 30 years old. You have the complete autonomy over what you want to do with your life, but I'm telling you that this is a destructive behavior. Do you want to just start thinking about end-of-life care right now, and maybe we should put this in? I mean, it may be controversial, but you know where this is going.
At 30 years old, just you want to be doing a DNR, man. But if you're
I don't see any
70s, though,
problem.
man,
But that's why I said I'm pushing back on it. Hey.
Because at the same time, you come to the ER every day, you're not going to see the same doctor every day as well.
But listen to what I'm saying. It's not about I should bring this idea that you're going to die young to you. It's the thought of I have autonomy. I have complete mental capacity right now. And if someone who loves me is ever forced to make a decision about my health, shouldn't I have this already written down?
That is true, but I just find it crazy. If I have a 35-year-old that comes in with a DNR, for like a drug overdose, like I'm gonna work them up.
Doesn't mean it's going to be a DNR, but they can at least say, I want everything.
Okay. Yeah.
See, we're just talking about end-of-life decisions. And when you're not able to make the decision for yourself, you're leaving it in the hands of somebody who's just essentially estimating what you want.
I think that would help someone be a little bit more careful if they heard that, honestly.
Yeah.